It's basically 2 tests instead of 1 when you put those 2 together, which was the reasoning behind extending that interval from 3 to 5 years, because you essentially have double protection against something being problematic at that point in time and for the next 5 years. So you have the protection of knowing the cells look normal and there's no presence of human papillomavirus. So HPV we now recognize as the cause of 99% plus of cervical cancer changes and cases. And so the idea behind checking for HPV is that if HPV is not present, then that patient would be at very low, almost 0 risk. But if it is present, they are at increased risk, with the caveat that most HPV infections do clear in time in about 70 to 90% of the cases within a couple years. The newer use of the high-risk HPV is just by itself as a 3-year interval screen. It's felt to be a reasonable option for women who are 25 to 65 years old. And if they have a negative high-risk HPV test, then they would come back in 3 years and just repeat that again. And if they had the type 16 or 18, they would go to colposcopy. And if they had one of the other 12 types positive, they'd be brought back in a year for a recheck. So it's kind of the reverse of a PAP that might have an HPV test added. It's an HPV test that might have a PAP added depending on the results. So it's a really new concept, kind of a reverse concept, but you're really screening for the root cause of the cervical cell problem. I do try to individualize for people what their personal risks are. So if they are smokers, we know that they're less likely to clear HPV, though it doesn't change their screening recommendation, but I use that as a motivator to quit smoking. But we have really great evidence that for healthy, non-immunocompromised women, if you do regular screening, whether it's every year, every 3 years with PAP or 5-year with co-testing, you're really going to catch things in a stage where it can be treated and not progress on to cancer.